Balance and Falls, Chapter 18. Falls are the most common mechanism of injury and the leading cause of death from injury in people aged 65 years and older. Approximately 30% of community living older adults fall per year, with about 10 to 20% falling more than once per year. In 2000, medical treatment for falls for those people aged 65 years or older was estimated at about $19 billion. When looking forward into the future, by 2020, the estimates put the number closer to $40 billion. And considering what we've discussed in the past about older adults continuing to rise in numbers, we're going to see more and more of this as we continue. We have to make sure and understand that falls in the elderly are a major cause of morbidity and mortality. The underlying causes of the falls is very complex in its nature, can be due to all kinds of different factors, which we will be talking about today. Although the majority of falls might be minor with little to no injury, there are both societal and personal costs associated with falls. Repeated fallers will tend to fall in the same manner as they did previously, and a single fall can result in fear of falling, loss of confidence, restriction in activities, social isolation, and dependence upon other people. Most falls happen to a variety of factors and not always just one risk factor. It's important to identify those at risk for falling and specifically the factors that might be at play and come up with an intervention to decrease those fall risks. There are all kinds of different types of risk factors from the extrinsic, including environmental, such as listed here, from the floor surface, poor lighting, furniture in the way, rugs, that sort of thing. Intrinsic factors, postural control mechanisms, weakness, gait issues, poor balance, etc. There are some other things listed in figure 18.1 in the textbook. That's page 333. And we'll be discussing these in more length today. On this slide, it kind of talks about the postural controls, a result of positioning the body's center of gravity over the base of support during both static and dynamic situations. From a physiological standpoint, postural control depends on the integration and coordination of these three body systems: sensory, central nervous system, and neuromuscular. The sensory system gathers essential information about the position and orientation of body segments in space. The central nervous system integrates, coordinates, and then interprets the sensory inputs, and then directs the execution of movements. And then the neuromuscular system responds to the orders provided by the CNS. Keep in mind that with these postural components will degrade with aging. So all these changes that we start to see here with aging can grossly affect somebody's overall balance. So, the basic definition of balance is keeping the center of mass over the base of support during both static and dynamic situations. There are all kinds of different neural components that comprise postural control, including sensory, central, and then effector components. When it comes to normal postural control, our body has to be able to adapt to the varying tasks that we have and environmental demands that we have with what we do day in and day out. And we have to use our sensory system as well as our motor system to help us identify how and where we are in space to improve our balance. Postural control during quiet stance. Here we should see that the body is aligned to minimize the effect of gravitational forces. There should be some muscle tone and some postural tone, but this shouldn't be very much because it's a minimal amount of movement that we should be doing. If you're seeing somebody sway, which we'll talk about here in a minute, that's a sign that the body's having to work too hard to balance and control. With the limits of stability, you have to think about the maximum angle from vertical that can be tolerated before somebody's going to fall over. How far can you shift front to back and side to side without losing balance? This is known as the cone stability. Postural sway, though, refers to small postural shifts from front to back and side to side during that quiet stance. Like I said, that should be fairly minimal. The cone stability is the next thing that we're going to discuss, like we talked about before, seeing how far somebody can move from vertical without falling. And everybody's is going to be a little bit different. The younger we are, we should have a larger cone of stability, and the older we are, the smaller that's going to be, that we can actually rebalance outside of that balance point. Postural sway. The larger the sway path, the greater the postural unsteadiness. And again, so the further somebody is able to sway and get back to that normal balance point, the better they are. But that can also lead to falls in the future. And there's different tests that can be done. Romberg test would be one of those. And I'm sure you all are very familiar with the Romberg test. But closing the eyes will decrease that visual input that somebody would have. And then we can start to see if there's other changes that are associated with that due to the visual changes. And this graphic just depicts the forward, back, and side-to-side movement when it comes to that postural sway. Postural control during perturbed balance. This is the recovery of stability required by movement strategies that control that center of mass over the base of support. There are limits of stability, and that's that distance somebody can move without losing balance or having to take a step. There are some specific movement strategies that we find whenever somebody is knocked off balance or loses their balance for whatever reason, whether it's a vestibular issue or being knocked off balance, but this one shows specifically how to kind of test those and look at those. So we have the ankle strategy from the far left to the hip strategy, and again, these just show where we're, what muscles we tend to use when we're trying to find that balance point. So with the ankle strategy, obviously we're using the muscles are more around the ankle to balance ourselves, so more of a distal strategy, to more of the hip strategy, which would be a bit more of a proximal strategy to improve our balance. But you can see with the first one, with the ankle strategy, it's going to be much easier, and they're going to have less of that postural sway if they were to get knocked off balance than with the hip strategy. Now the center of gravity is moving much further away from the center of gravity, and therefore they're at much higher risk of falls. The next one would be the arm strategy. So again, putting the arms out to kind of stabilize. And then the last one here is showing the leaning into the push to try to counteract that balance disturbance. So again, showing the ankle strategy, hip strategy, and then step strategy, which we'll talk about in a moment. But if somebody has more of that hip strategy, that's a pretty moderate instability. We would expect to see ankle strategy from somebody that's healthier, younger, has better balance. Then the hip strategy is one of those other balance strategies that we'll see when people have more dysfunction when it comes to their balance. So again, that control is going to be more proximal to distal here. And those older adults do tend to use more the hip strategy rather than the ankle strategy. This just kind of shows what we'll see if we have somebody using a bit more of the ankle strategy here and the forward sway. So if they were to sway forward, what are they going to use to counteract that? So we're going to use the muscles on the posterior chain of the body to stabilize that. If we're using the ankle strategy and doing a bit more of a backward sway, again, we're going to use muscles on the anterior chain of the body to help stabilize. If we have the hip strategy, again, somebody's pitching forward using the hip strategy to try to counteract, they're going to be very dominant in the abdominals and the quads. And then if they're having that backward sway with the hip strategy, they're going to be using a bit more of the paraspinals and the hamstrings. With the perturb balance movement strategies, stepping and reaching strategies are the only compensatory reactions to larger perturbations, and these are going to have a very significant role in being able to prevent falls. When our patients are a little bit more nervous about what's going to happen, they're not going to be willing to step forward because they don't trust balancing on one foot in order to be able to step forward. But this is also a great way if they have a larger perturbance. If somebody's really pushing them or something knocks them off balance, they're going to use that stepping strategy, which is what we want to see with them. Just recently, I was working with a patient that has fair balance. She tends to get off balance and is very anxious about falling. And we've been doing some stuff to work on some stepping strategies such that whenever something happens to her, she has that kind of ability to step out and regain her balance without feeling like she has to use just that hip strategy, which was her primary mode of balancing herself before. Reaching movement or strategy. So you're going to move forward, you're going to see somebody's moving out, grabbing an object or reaching for something to try to use an object for support, even if maybe there's not an object. But those are those people that you see that are going, cruising from back of the couch to back of the chairs to armrests to walls, using that to kind of balance themselves as they move. That means that they're very unsteady on their feet, and one of those things that we can work on with them, coming up with better strategies that are safer for them. Suspensory strategy. And so that just shows bending the knees during standing or ambulation, which allows them to enhance stability. And if you think about why this strategy might be used, this is going to be one of those things where, if we're using that suspensory strategy, like right here on C, they're going to do that to decrease and lower their center of gravity over the base of support. And that makes them much more stable. So it gives them a better postural stability whenever they go into this kind of a suspensory strategy. So that's another way that somebody can improve their balance. Perturbed balance of the central nervous system. That response can either be protective or corrective depending on what the patient feels is coming at them. And then we have anticipatory postural control. And we do want to see this with our patients. Anticipating what might be coming, but we don't want them moving ahead of time before something happens. But this anticipatory postural control just refers to the postural adjustments that are made before voluntary movements to minimize disturbances in their balance. So it's kind of that feed-forward system. But if you see a ball coming at you, if we're trying to do some sort of balance activities in the clinic, what are we seeing them do ahead of time? Are they waiting until the ball hits them before they do something? Or are they kind of frozen in place? Or do they use a stepping strategy? But those postural adjustments that are made are those anticipatory postural control changes based on what they see coming towards them. Perturbed balance of the central nervous system again. Reactive control, so maybe they're using more of a feedback loop as opposed to the feed-forward loop. So they're responding to something after it happens. And then we can also use that corrective strategy, like we talked about earlier, the ankle strategy, or protective, such as falling to cover your head, or covering your head when you fall. Obviously, it doesn't fix the problem, but it minimizes, hopefully, your risk of injury. Our body does a great job of compensating when it needs to. And it does this by regulating the central nervous system and activating muscle synergies in related joints. So force of one body part does not cause an instability in another. So if you think about leaning over if you're sitting in a chair and you're going to lean over to pick up something on the floor, you don't fall out of the chair, right? Because you have different mechanisms in play to help stabilize. And same thing, if you're going into that hip strategy posture, like leaning forward from the hips, your body's going to react by extending the neck just to kind of look and see where things are going and what they need to do next. But that's that kind of body's defense system. There's quite a few different processing tests for the CNS that we can do. There's all kinds of manual tests of postural perturbance. And the book kind of shows a couple of them by the therapist pulling patient at waist level several times, various angles, various degrees of force, just to kind of see what they do and how their body reacts. Do they use an ankle strategy? Do they use the hip strategy, the stepping strategy, any of those suspensory strategy? And you might want to note that. So if that's something you're trying to do to test, just make sure and note what kind of strategy the patient uses. Looking at that sensory system again, during that perturbation of the balance, adults tend to rely on a bit more of the somatosensory inputs, where children tend to use more of that visual input to help them understand where their body is in space. This interaction of the senses allows the modification that's needed to maintain their stability in their environment. Normal postural control system, we do see the body working in the different senses to tell us where we are in space. And each of those senses provides a different frame of reference for that postural control and helps the body know where they are in space. So we have the normal postural control system with the foam and dome test. I believe you guys have done this in class and in one of your other classes, but taking away the visual input, putting them on an unstable surface, so they have to use a little bit more sensory input to know where they are in space and look to see what kind of strategies they use to maintain balance. So with vision, we're going to provide, that's going to provide obviously where we are in space and what our body wants to do. Tells us, where we are in relation to the horizon. So we can do different things. We can use the acuity, using the Snellen and eye chart, looking at depth perception, and then peripheral vision. We're going to talk about these in a later slide as well. From the somatosensory system, that's going to provide the information about the body with reference to any supporting surface that it's on, either standing on or sitting on. And the body's going to get information from joint receptors, the GTOs, mechanoreceptors, all that kind of stuff to tell us where the body is. The vestibular system, that obviously provides information about where the body is in reference to gravity and other forces at play. That information received from the vestibule is responsible for positioning and linear acceleration. And obviously, as I know that you guys have learned in other classes, the semicircular canal is very responsible for that rotational movement, and again, letting the body know where it is in space. When it comes to the vestibular system, looking at gross functional tests, looking at an object while turning your head, reading a book while walking, having patients close their eyes while marching in place, having patients look right and left while you're having them walk down a hall, or even looking for signs, or I'll have post-it notes on the wall with different numbers, having them try to gaze and look about while they're trying to do another task such as walking, can test that vestibular system and see how they respond. Postural control is going to require using the sensory system, the central processing system, and the effector components of the body. All three of these systems in the postural control are very complex and multifaceted. A problem or any sort of impairment in one area may affect several other areas, resulting in a greater issue and problem with posture specifically. And the sensory system, with aging, the vision is going to decrease most of the time in acuity, contrast sensitivity, and depth perception. With the aging also we see vestibular system changes, dizziness and unsteadiness in some of our patients, and so making sure that we're asking about those kind of changes, whether it be dizziness, ringing in the ears, those kind of things that we might see, especially if a patient isn't sure why they get off balance or why they might fall, making sure that we're assessing this. And then you also can get a decrease with aging in proprioception and vibration sense. The CNS and the central processing system with aging can result in slowing of sensory information to the brain, that increased postural sway, increased incidence of co-contraction, so everything kind of freezes up, and then that increased use of the proximal to distal control for the balance, like we talked about the hip strategy, as opposed to using distal to proximal control like the ankle strategy. When it comes to the effector system, we could see a decrease in muscle strength, decreased range of motion and flexibility, and then just an overall increased stiffness of the connective tissue, which can also feed into that co-contraction. We can also see cardiovascular changes, so that can also affect our postural system as well. When it comes to looking at the CNS and the postural actions that our body does, our responses of muscle strength, endurance, torque, flexibility, range of motion, postural alignment are all really important when it comes to decreasing our patient's risk of falls. And then we have other assessments that can be done as well. Environmental, it's very important to make sure that you're asking about the patient's environment that they might be falling in, any sort of cognitive tests that need to be done to see if maybe there's some confusion on behalf of the patient. And then medication as well can also definitely play into postural imbalance insufficiencies. System review and test. We've got all the same thing that we would do for anything else, but specifically when it comes to postural stuff, making sure that we're looking at any sort of sensory issues, somatosensory problems, integration of the sensory, neuromuscular testing, aerobic endurance, environmental discussion as well, psychosocial assessment, just making sure that the patient isn't fearful of what's going on and therefore they're prohibiting some of the movements that the body would compensate with anyway. Fear of falling, so maybe they're grabbing onto things. And then participation in activities. So if they're decreasing their participation in activities, their body isn't working near as efficiently as it could be, and that might be something we'd have to assess as well. When it comes to the vision, there's obviously some specific vision tests that can be done. And so making sure that you're looking at that. Visual acuity can be estimated by using the Snellen chart like we talked about before. Contrast sensitivity, important in detecting objects, specifically on the ground. If you have some sort of carpet or pattern on the flooring and thresholds, excuse me, that can definitely affect somebody's ability to move around in their space. Depth perception, so distinguishing distance between objects. You can test this by putting your pointer fingers out in front of the patient with them at different distances and then trying to get them to the same parallel distance and have the patient tell you when they feel like it's at parallel. And if it's off by 3 inches or more, then their depth perception may be a problem and they might need to be referred on to somebody else, maybe an ophthalmologist for more testing. And then visual field restrictions, like peripheral vision issues might be an issue, and then testing their peripheral vision to see how that is. And then vestibular assessments like we've discussed. The proprioception can be an issue as well, so making sure that we know where the body's sense of position and body awareness are when they're moving. You can do some testing here, and this is pretty easy to do with the patient sitting or resting, and then taking just their great toe and moving the toe up or down in space, and having them doing that passively to the patient with their eyes closed to see if they can notice that there's movement going on there. A normal test would be the fact that the patient can notice that at the great toe, but if they're not noticing that, then you kind of move up more proximally, so move the ankle up and down and see if they can tell where the ankle is in space, the knee, the hip, those kind of things. All done with the eyes closed to see if they can, how their proprioceptive ability is. Vibration testing, you can use a tuning fork at the first metatarsal head to see how they do with that. And then cutaneous sensation, we've got the pressure and 2-point discrimination testing that can be done as well. So we need to make sure we understand the interaction between all of those modalities that we just discussed. Pages 340 and 341 and box 18-3 in your book provide other testing measures as well. So you might want to just look over those, but most of these are probably ones that you've done previously in other classes. The neuromuscular testing, pretty basic and stuff you guys have learned since practically day one of PT school, looking at their muscle strength, their range of motion, and their endurance to see how they're faring in those areas. Strength, obviously, and we're going to talk about this more as the semester progresses, but we see a decrease in strength for older adults as they get older. So strength testing provides that information and lets us know whether the patient is able to generate enough muscle force to recover from some of those balance disturbances. Obviously, manual muscle test is a traditional way of testing those muscles, and it gives us a good objective finding. You can also do isokinetic testing at both slower and faster speeds to see how they do, to see if they have the ability to generate the torque generation that we would need if they had some sort of a fast movement and possibly a fast fall. And then looking specifically at ankle mobility and ankle strength, because any of those limitations, again, decreases the risk of having an ankle strategy and therefore increased risk of falls. So there are quite a few different functional performance tests that can be done. So with aerobic endurance, you can do all kinds of different testing here. An easy one to do, and one that I tend to use quite often, is a 6-minute walk test. It's a great way to see how the patient's endurance is and get an idea of whether or not they're slowing down or speeding up as they do more walking. and that's a great test and easy to administer. Functional gait and balance, there's plenty of balance measures, and you guys have used those before, and some of the pages in the book talk about some specific ones. Environmental assessment. We will go over this later in another chapter as well, but just making sure that we're asking questions about, where they fell, if they remember why they fell, did they trip on something, were they just dizzy, was there something in the way, or was there something they thought was in the way that maybe wasn't? So making sure that we're assessing all those. Psychosocial. So again, we've talked about this before, but understanding what their social network is and their support network, and then making sure that they have a very supportive environment to decrease their risk of falls. So is it a lighting issue? Is it, if everything's pretty dim, or they're having to get up in the middle of the night to use the bathroom, they don't feel safe doing so? Do we talk about using night lights and those kind of things as a safety mechanism and a way for them to move about more safely in their environment? Behavioral or cognitive issues. So does the patient maybe have impaired cognition? And we have to make sure that we're addressing that as well. So are they having any memory deficits, any dementia, depression, those sorts of things? We need to make sure that we're asking the right questions and finding out the answers to those as we go. So 1/3 of older adults who experience a fall are going to develop a fear of falling. Like we've talked about before, if somebody has already fallen, and especially if they've hurt themselves, they're going to probably be more sedentary because they're going to be more fearful of falling again. So we just want to make sure that we're asking those questions if they've fallen before, how that happened, what they've done since then, making sure that we're talking about using an assistive device if necessary, or did the assistive device get in the way, just getting as much information as we can. There's a couple different tests that we talk about here, the falls efficacy scale, and that's listed in your book on page 348. So again, making sure that we're asking the questions of how active the patient is in general in their life, and again, this is going to depend on what environment they're in. So if they're in an outpatient environment and they come into your clinic or your facility, making sure that you're asking about what activities they do, and if that's normal for them, or if they've decreased some of their activity level due to falls or fear of falling, and then just getting some more specifics there. So there's a few different life habits questionnaires that you can use, and page 348 in your textbook has a specific one that you can look at there. And then when it comes to interventions, we want to make sure that it's based on the assessment of the patient in front of us. So you can have an idea of what you might think is going on based on reading the history of the patient, but once you get in and actually do the assessment, that's how we want to make sure we're basing the intervention on. Obviously, the ultimate goal is to maximize the independence of the patient in their mobility and their function in their environment that they're in. And you need to make sure that you're identifying any treated or deficits that the patient has, and figure out if they're modifiable. The therapist also needs to identify and help the patient compensate for deficits that cannot be modified. So if there's things that can't be changed, if the patient is getting weaker and the weakness is affecting their balance, then maybe it's time to discuss using some sort of an assistive device so that the patient can remain active as possible in their environment, but still decrease their risk of falls. Your textbook provides a few other factors and strategies that you can look at, and feel free to just look over those. You won't be tested over those, but good to know for future reference. And really at the end of the day, with fall prevention, the idea of what we do in assessing and intervening for the patient is just to prevent the next fall. We can't always stop them from happening initially, but our goal is to decrease any of those risk factors that we talked about earlier to prevent any future falls.